Hello, welcome to this new podcast. Today we're going to talk about epistaxis. Epistaxis means bleeding from inside of nose. Important causes of epistaxis. Well, the most causes of epistaxis in children and young is traumatic, after nose peaking, or after upper respiratory tract infection as coryza or sinusitis, led to dryness, crusting, and hypertension, which on removal by nose peaking lead to epistaxis. In any child with unilateral epistaxis, foreign body should be ruled out. Any young male with profuse and recurring epistaxis should be investigated for angiofibroma. The most common cause of epistaxis in an elderly person is hypertension. Other causes of epistaxis are blunt trauma, anatomical deformities, septal deviation or septal spur, predisposing the deviated part to drying effects of air and crusting, antiplatelet and anticoagulant drugs. Topical nasal drugs such as antihistamines or corticosteroids may cause mucosal dryness and hypertension, leading to epistaxis. Granulomatous disease such as sarcoidosis, beginner granulomatosis, tuberculosis, syphilis, and rhinoscleroma often lead to crusting and friable mucosa and might be a cause of recurrent epistaxis. Intranasal tumors. Another one is bleeding disorders of thrombocytopenia, hemophilia, and von Willebrand disease, liver disease, hereditary hemorrhagic telangiectasia, or Osler-Rendu-Beger syndrome. And this is an autosomal dominant condition characterized by telangiectasis, or a small vessel malformation of the skin and mucosal lining. The most common complaint here is recurrent epistaxis. Size of epistaxis. Overall, 19% of epistaxis occurs from Little's area. The most common site in children and young is the Little's area, or Kesselbach plexus, present in the anterior inferior septum just above the vestibule. Four arteries contribute to Kesselbach plexus. The first one is the septal branch of sphenopalatine. This is a main artery of Kesselbach plexus, also known as artery of epistaxis. Sphenopalatine is a branch from the maxillary artery, which in turn is a branch of external carotid. Septal branch of greater palatine is also a branch of maxillary artery. The other one is the septal branch of superior labile. Superior labile is a branch of facial artery, which is a branch of external carotid. Anterior ethmoidal artery. It is a branch of ophthalmic artery, which is a branch of internal carotid. So most commonly epistaxis is arterial. Epistaxis in young can be also be venous from the retrocolumellar vein, which runs behind columella of septum and after passing through the floor forms a plexus on the lateral wall of nose beneath the mucosa. In elderly, epistaxis is posterior. The site of this posterior epistaxis is on the lateral wall of nose, inferior to posterior end of inferior turbinate, known as Woodruff's plexus, where the anastomosis of sphenopalatine artery, which posterior pharyngeal artery occurs. The management of epistaxis. Well, the first step of management of epistaxis is to pinch the nose tightly and side bending forwards. This is known as Schroeder method. If bleeding side can be recognized and it can be cauterized by chemical silver nitrate or electrocautery. If bleeding continues, anterior and posterior nasal packing is done. Anterior nasal packing is done in both the nostril for better pressure on the nasal septum, where the little's area is present. Posterior nasal packing is done by putting a gas pack into the choana and nasopharynx from behind the soft palate. If epistaxis is not getting controlled by the above, arterial ligation has to be done. Preferred technique is TESPAL. TESPAL means transnasal endoscopy sphenopalatine arterial ligation. This is done where a sphenopalatine artery enters the nasal cavity from the sphenopalatine foramen, 1 centimeter behind the posterior end of the middle turbinate. TESPAL has no surgery replaced maxillary and external carotid ligation. If breakered, the maxillary artery can be ligated in the sphenopalatine pterygopalatine fossa, which lie just behind the posterior wall of maxillary atrium via Catwell-Look operation, and the external carotid can be ligated in the next above the superior thyroid artery. In a patient of epistaxis not controlled by ligating the external carotid, epistaxis is known from the internal carotid branch supplying the little's area, anterior ethmoidal artery. The anterior ethmoidal can be ligated in the medial wall of orbit, 24 millimeters posterior to lacrimal crest. In an elderly patient, epistaxis is managed by nose pinching and control the hypertension. The underlying cause of epistaxis should be found and managed accordingly. In patients of hereditary hemorrhagic telangiectasis, beside the usual management of epistaxis, as discussed above, and it can be treated by laser. Some cases require septodermoplasty, where septal mucosa from the little's area is excised and replaced by a split skin graft.